So thank you to everybody for arriving to listen to this. And again, Naina, thank you for agreeing to talk to us about how we can use extra methodologies in our clinical research. I'm going to hand over to you right now. Thank you.
Thank you for this opportunity to share my research worldview. And I hope that all of you will benefit from today's session in some way or the other. I just need to get into slideshow. Okay. Is that clear to everyone?
Yes, it is.
Yes.
So I think it must be, because there's nobody saying we can't see anything. So today we're really looking a closer look at qualitative research application in the health sciences. And I think the way I've approached this, it could be applicable anywhere. But I think there are challenges in the qualitative approach. And so those are some of the things that I will just touch on before I deal with the application. So in terms of qualitative research, that the biggest difference is that instead of finding patterns and averages or making predictions and testing causal relationships and all those kinds of things, in the qualitative approach, there's various methods that are used. These could be observation interviews, focus groups, action research, there's visual methods, photographic, document reviews, grounded theory, and all of those. And the main objective is to explain or to critique social phenomena that are generative in essence. So they're not generalizable often, but they lead to interesting questions, interesting dilemmas, interesting interpretations, which leaves it to the reader of your research to kind of say, how does this apply to me, my patients, my practice, or my values, knowledges, and so on. So qualitative approach has this dimension to it. And I think one of the reasons that it has been downplayed in the hard sciences, in the medical sciences, and so on, is this entire notion of generativity, because most of it is not generalizable. And we know that medical practice is dependent on having a range of, or a set idea in which everyone agrees that that is the best way to do it, and then to apply it across the board. But I think the medical profession is now also realizing that there are nuisance variables which cannot be sort of designed into the research process, because there are too many of these that are not known, that are unanticipated, that they cannot be forethought about it in order to factor it into the design process. So these kinds of what you would call nuisance variables in the sciences are what we call complexities in qualitative research. And complexity is something that we embrace and something that we think is absolutely necessary for deeper understanding. So, and I think there is a shift, even in the hard sciences, towards some of these ideas now. And perhaps the question we can pose, why now? Why suddenly, or not suddenly, but in recent years, the shift towards qualitative approaches? I think because qualitative researchers have upped their game. They've now got theoretical, conceptual, and methodological evidence for respecting its approaches. So there is much more justification and evidence to motivate those that are outside this terrain to say, yes, there is a research dimension to it, that it's not nonsense and busy work. Because for a long time, qualitative research was not respected at all. It was even called non-research. But there is an acceptance, and as Colleen has said in her introductory comments, there are studies that are coming out from our own students at UKZN, pushing us in this direction. And so the objective then would be, if we're moving in that direction, let's get acquainted with it. Let's know it in a deeper way so that we can do justice to our research. And when we present it to our peers in the medical field, that they will respect our findings, because there is deep research processes and procedures that make it valid. So I think that's the reason for the turn in recent years. So one of the things that makes qualitative research slightly more challenging, not that quantitative research is easier, but I think this one has some challenges, and it has to do with multiplicity. So it offers multiple theoretical and philosophical lenses to make sense. So if we take interpretivism as your worldview, then it means that the objective of the research is to bring about understanding, not to do any change or anything. So maybe it's just to understand the mind of somebody who is undergoing some kind of trauma. And the reason for understanding is, would that state of mind affect any intervention that the medical practitioner has to offer? So it's about understanding this relationship between the state of the mind and the intervention, the medication, the procedure, or whatever, because there is so much that is unknown, that is beyond our understanding. And so this is one way to start. Then there's a worldview called critical interpretivism. And that is that we want to understand the dimensions and the nature of power relations and how that affects our practice. So if you're a medical practitioner, and if you don't have a really good understanding how the title doctor, the white coat that you wear, the stethoscope that hangs around your neck like a necklace, how all of those indicate a certain power and authority over the person over which you are intending to take care of, and how they relate to that. So research like this can reveal to all of us what are the some signals or the signs of power that shut down, that prevents a patient from telling you exactly what they felt. They might think, what I have to say is so silly. I don't know whether I can tell the doctor about this. So understanding that might be a way. Critical theory. And this is to emancipate or liberate. And it need not be about the patient. It might be about, working as a researcher in a laboratory with a professor at the head, and to see what can you do as a researcher who works under a highly respected international authority to liberate yourself in a way that you can take ownership of the research that you are undertaking, that you can take ownership of the writing, that you can dictate based on your evidence, the kinds of thesis that emerges and so on. So critical theory, if you understand that, if we do enough research using that lens, we may find ways in which we can emancipate ourselves or others for that matter. Then there's feminism, which allows you to disrupt gender regimes in the workplace, in the practice, in the curriculum, interpretation, and so on. So feminism will give you the tools and the perspectives to look at any situation and understand how gender power operates in the setting and what can be done or undone. But we need studies in those from that perspective. Then there's post-structuralism, which is a way to research and break things down to see how they actually do the opposite of what is intended. So deconstruction will often reveal some kinds of ironies, paradoxes, contradictions, and so on. And it's very important. Why is it, for example, a post-structuralist lens will allow you to understand why some medications will cure some and kill others, for example, because it's a special lens that looks at it, or why a particular practice results in perhaps more negatives than positives. So going into that, because you're going in with the lens to look for that. And it's not an accidental finding. Then there's postmodernism, which is to critique the present ways, cultures, and habits of doing things, and to perhaps create some disorder, some chaos, because chaos also has some pattern to it. And then there's post-humanism. And in this worldview is to decenter the human being. That is to say that everything that we do at the moment is to improve human life. But if you move into post-humanism, then it's to put other things at the center, like the environment, like animals or plants, or the survival of the planet. And then humans move to the side. So these are all the kinds of different possibilities. So you see, in qualitative research, you have to choose one of these worldviews. So it differs from the kinds of research that you've always done, in which there was a common sense and a commonly accepted and agreed understanding of what the world is. A heart is a heart is a heart. So whereas in social sciences, we've always known that a smile is not a smile, because there are other things behind it that we have to go to either understand, to emancipate, to deconstruct, to critique, and so on. So I hope and we can take more questions around the worldviews. I haven't done it in detail, but just to signal that this is what makes qualitative research different if you're moving in that direction. The other aspect of qualitative research is that you're dealing with multiple truths. So if you look to the image on your right, so there's the object, a cylinder. But it's also true that it could be seen as a square or as a circle. So there are multiple truths that coexist depending on one's perspective, because the truth of the square and the truth of the circle is that it's a projected image. It's not the actual object. But because we don't know how the mind projects, we accept those as truths. And our idea in qualitative research is not to go and challenge the truth. Unless, of course, you're working in feminism and critical theory, then, of course, you do challenge the truth and displace it with another one. But still they coexist simultaneously. And so you can see how it differs to the approaches in sort of the health sciences, where community health nurses use various approaches, right? So it's the I can't pronounce that, epidemiological approach, problem solving, and evidence-based. But all of these are accepted as truth, as an authentic way of understanding community care. And it's also possible that you could use all three simultaneously or in conjunction with each other, or use two or just one of them. So that's what we mean by the truth, that there is a multiplicity. The same goes to perspectives. There are many perspectives. So whose perspective are you going to write or do your research? Is it from the care user, the care provider, or the care manager? Because each one has an agenda. Each one makes assumptions. Each one understands the world and their place in the world. And so this is what we try to do in qualitative research. We could do a study just on the care user. So that means on the patients, or just the care providers, those who dispense it, or the person who's overall in charge of a center where medical care is provided. Or we could say, I want to look at the relationship between the care user and the care provider. Or you could decide, I'm going to look at the management of care in a setting with all three, what you call groups of participants. So there are choices that one could make about how you would research high quality care. All right, so it offers you far more options than I think the quantitative approaches. And I might be mistaken because I'm not so well informed of the qualitative approaches. And I will depend on Colleen to do some corrections if I go off the track. So there are also many realities. Think about the patients that we serve, right? They could come from this mention on this extreme left, or live in sort of one of these informal homes. And you can get a clearer perspective when you look at it from a bird's eye point of view. Just look at the cramped way in which some people live their lives, and the spacious, beautiful, proper settings and arrangements with the roads and so on of those middle classes. So when we doing our research, we have to think about who the participants are, where are we drawing from? So even if you're working with doctors, a doctor who grew up in a tin shanty has a different perspective of working with patients to somebody who grew up in a huge mansion, living in the countryside with servants and every kind of resource and luxury at their fingertips. It doesn't mean that the one will be kinder and the other will be harder. No, that's not what I'm saying. But there will be a difference into perhaps the attitude to the patient, or the understanding of who the patient is, and so on. And so when we're doing our research, knowing the context becomes important. And you can see why it's not generalizable. Because everyone who reads your research will have their own viewpoint that might differ or cohere with the one that you are proposing. So another complication is there are many attitudes, values, and beliefs. I mean, what's going on in the United States makes for very interesting observation around the issue of abortion, the right to live, and as the Swan said, keep your laws out of my vagina. So there are all these perspectives, and a research might be to make sense of all these kinds of signs. So a research could be done entirely on whether you regard these as attitudes or values or beliefs, is just to make a selection from the internet of all of these kinds of posters and to try to make sense of it in terms of values, beliefs, and attitudes towards life. The right to, a woman's right to make a decision about having a child or not to have a child. And what are the ramifications when a person says adoption is better than abortion? When we track it against the horror stories of some of the children who were adopted and how their lives then unfolded, or the children who were placed in homes and what happened to them, or the child who was moved from one foster parent to another foster parent. And what are the ramifications of forcing a woman to give birth when we know there are thousands of children who nobody wants to adopt? Or about the health risks of somebody who might die, for example, if they go, continue with the pregnancy for the full 9 months. I'm trying to think of what do you call that pregnancy that takes place in a tube, and so on, or the 10-year-old girl, so who was raped and then had to carry the baby and so on. So there are many things that one could do in terms of research, but can you see the complexity around us, that there are so many values, and what you have to do in the research is how do you manage it? And of course, that depends on your theoretical framework, which is something that you don't really do, I think, in your research. You never had to consider that. But when you're doing qualitative research, it really shapes and directs the way you understand, the way you analyze, the way you then emerge with your findings in the study. And so, of course, people talk about that it's subjective. That is the nature and essence of qualitative research. It does not pretend to be objective. So what is the rule in qualitative research? Is not that we are against objectivity and for subjectivity, but we try to reduce subjectivity as much as is possible. So it's not just about subjectivity, we try to reduce it. And as I said, in qualitative research, we have upped our game, and there are ways and means in which you reduce subjectivity and move more in the direction of objectivity. But that's for another day's discussion. So then there's complexity as well that one has to consider. Just look at the complexity engaged in a decision about going to a doctor that a patient might engage. And so your studies might reveal all these kinds of complexities, the decision-making processes that a doctor makes about, do I operate on a 90-year-old patient or not? And what are all the things that are considered when making those decisions? And I might then interview 20 healthcare professionals about how they make decisions about undertaking or providing surgical intervention for geriatric patients in the 90 to 100-year age, for example. So that might bring about some understanding, but you are dealing with complexity. But that is factoring it into the research. But the other aspect of qualitative research is that complexity might emerge as a finding from your study. And then one has to manage that. So it's not always about simplifying and coming to a neat resolution. It's much more complex. I hope I'm not going to frighten you away from qualitative research. And then, of course, there are paradoxes. I came across this very interesting article, and that is why I put down the source, the Grey Swan Guild, and the paradoxes of the 2020 pandemic. And I just picked out the one about the pandemic. And one of the findings was that the pandemic brought us closer together. So one of the findings was about how well do you know your neighbors? Before the pandemic, 20% said, my neighbors are total strangers. After the pandemic and the post-lockdown, 56% said we've gotten to know each other much better. So that is one of the positive outcomes. So this is paradoxical because the pandemic was supposed to be something that's really bad. So many lives were lost. So many complications arose. Doctors had to face terrible decisions around patients, who to admit, who not to admit. So much suffering, so much pain, so much death. And yet, here's the paradox, is that there was something of some benefit that emerged out of it. So qualitative research can reveal that. So how would one apply qualitative research in the health sciences? And so here are the kinds of methodological approaches. So narrative inquiry. If one goes into this, that means that your study is concerned with people's stories. It could be the healthcare professional stories. It could be patient stories. It could be caregiver stories. It could be the stories of cleaners in a hospital or in a clinic. It could be healthcare researchers' stories. So you could use any group or multiple groups in order to come to a deeper understanding, or to understand power relations, or to find paradoxes, or to critique it, and so on, using narratives. So narrative inquiry has two parts to it. Sorry, I get hiccups when I talk for a long time. So the two parts are narrative inquiry is the way, so the first part of it is how do you construct the narratives? And then the second part is how do you analyze the stories? So through narrative inquiry, you generate stories, which becomes your data for the study. So your data is quite a different kind, and it is written up as small essay or something of that nature. And it could be written by you, the researcher, or it could be written by the participants in the study, or it could be done as co-construction, the researcher with the participants. Then one could do case studies. And a case study here could be the way you wish to define a case. Is the case the professional health caregivers? Or is the case about the patients? Or is the case an institution that offers health care? So you have the choice of choosing the case, and then, of course, applying the methods to it, which I'll speak to separately. Then there's discourse analysis. And discourse analysis really looks at the way one analyzes what we call utterances. So utterances are not sentences or statements. An utterance could be something like stop or sorry. So sorry is a really nice example. What is the difference when one says sorry or if one says I'm sorry? And so a discourse analyst will look at these two kinds of utterances and then make some kind of sense or meaning about it. And so discourse analysis is really about picking up these. So you could be sitting in a hospital and just hearing the different kinds of utterances that are made throughout the day. Don't run, shh, be silent, or something of that sort, and then to try and make some kind of sense of that. Phenomenological research is really looking at a phenomenon. So you might decide that care is this big thing that I really want to understand in a deeper way. I might look at it from a feminist perspective, or from an understanding perspective, or from a liberation perspective, and so on. So it might be very interesting to do a study to see how people interpret the notion of care. Recently, I spoke to someone, and it was quite, it was a surprise to me to say that when my family came down to look after me, I felt I was in prison. And she was kind of describing how she was under constant surveillance and so on by the members of the family and so on. So it's quite a different way to looking at being taken care of, for example. Then there's life history. And here you could do a study of a person's life, going back from birth to where they are at the moment. And life history research, I think, is maybe of particular use to those who are researching genetics and disease. So trying to understand, the history, and maybe not just in genetics, the emergence of a disease or an illness, and going back in time to understand what happened. How many times did you fall, hurt your head, break your bones, and so on and so on, using a variety of instruments and methods to get to the story over a life course. There's also life course history. Then there's self-study. You could do a study of your own practice as a healthcare professional. And so you might want to research how you can improve bedside care, for example, or how you could improve the way you communicate with patients. And so you engage in the study, hoping in some way by the end of it to transform some aspect of your practice. And you're in charge because it's about you and yourself. Then there are biographical accounts, which is close to life history. There's ethnography, and ethnography is the kind of study which allows you to observe and be a participant and be a researcher in a setting. What ethnography normally refers to it as a natural setting, but I don't think a hospital is a natural setting. I would say it's much more an authentic setting for understanding how a healthcare organization operates. And so for an ethnographic study, which might be really good for a PhD, because you might want to spend 6 months to a year embedded in that space and accounting every day for what is happening, so that at the end of the study, you can tell us something about this culture of this particular hospital or clinic, or even a medical practice, or an oncology unit, or a radiology unit, or a laboratory setting. So there are endless opportunities to do ethnography. I regard myself as an expert in ethnography because my PhD was one. It's done very rarely in education today because most people are working full-time. They cannot take 6 months to a year to spend in a setting. So that is one of the limitations. Then there could be a philosophical introspection. You might just do try to understand the philosophy of care, or the philosophy of trying to think something in you know, how people respond to medical treatment. So if you tell a person take a tablet 3 times a day, what would that mean for a long period? What would that mean from a philosophical point of view in what it means to be human, what it means to have things done to you, what it means to be regulated, to be normalized, and so on. And so it could be a philosophical essay and introspection and research around that. And then, of course, there's participatory action research, and this is often used in community health practices where you're working with communities and you want to either change their habits of care or their treatment regime or something or the other. And then you work with the participants and together you design a study and they give inputs into what the intervention should be, how it will be tested, how this thing would be written up, and how it would be documented, and so on. So these are some very interesting ways of approaching health sciences. I think I want to stop there before I go a little further, but I'd like to take any kinds of questions for clarity or understanding at this point.
There are some questions in the chat that I think we should address. From Shamila, she has a question: are pilot studies a norm within this research design?
It's not a norm, but it is highly desirable. And the main reason for the pilot is it's to refine the instruments. So you might test out, you've got an interview schedule, you want to ask a number of questions, and you try it on non-participating persons or individuals. And you find that the data is not coming through. So either the language you're using is not suitable, maybe it's too theoretical, it's not at a level in which people understand, or the questions are ambiguous, or the question is framed in such a way that it they come up with a one-word response, yes or no. So a pilot is very important for that. The pilot also tells you or alerts you to what kind of probing questions, the follow-up questions, because we mainly use unstructured interviews or semi-structured interviews, which means we have some idea of what we're going to ask. But it alerts you to, I need to probe deeper here. When that comes up, I need to ask that. So you can prepare better for the interview. If you're using an observation schedule, it could be that when you use it in the setting, because you want to do some observation, you might find that, oh my goodness, there's things over here that I don't have in my observation schedule, but they exist in the setting. So the refinements and so on are there. Pilot studies are also important because they hint to certain kinds of findings that you can anticipate. and kind of start reading up about that and so on. So certainly, yes, I normally, I get my students to interview me because I always mess up the answers. I will always interpret it ambiguously to force them to look at the questions again and then to refine it. So, yeah.
I think I have a rule of thumb. If you're using any instrument, even if it is just a couple of questions, you pilot them.
Yes.
Dushima, then we were talking about subjectivity and objectivity. She says trustworthiness reduces subjectivity, I think. Would you like to comment on that?
Okay, so trustworthiness is one of the validity constructs that are used in qualitative research, and I haven't touched on validity at all because we use different kinds of validity. But trustworthiness is the way in which you engage with your participants, the way in which you write, that tells us we trust you as a reader. So it's not, it's like you have to prove to us that what I've done is trustworthy. So when you say, I did my research in an authentic setting, that means we want a deep description about, we don't need to know exactly where it is because of confidentiality and ethics and so on. But we need a description of that setting, which kind of gives us an idea. So if you said, I worked with middle-class individuals, and they live in these kinds of homes and they had this kind of schooling and this is the kind of income and so on, the household income and so on. And then when you are making your what you call it, your interpretations of the data, we kind of see whether it goes with that, whether you contradict yourself and so on. And then it also works, trustworthiness also works with multiple truths and multiple realities. If you are only offering one reality from multiple participants, then we feel that your work is not trustworthy. So it operates in a very different way. It is in others. And of course, we also look at the instruments. So trustworthiness is increased or improved when in your methodology, you tell us the pilot study, what you did. This is the instrument as it was, and what kinds of changes were made, and so on. Yeah. So I hope that I'm just trying to...
She goes on to ask, what is the difference between narrative inquiry and phenomenology?
Okay, so in narrative inquiry, the whole inquiry is based on people's stories, right? So the stories. Phenomenology is on experiences, what they call lived experiences. So a story might not be a lived experience. Okay. I could be inventing somebody else's story as if it's mine.
Yeah.
No? And of course, there are other deeper differences between those. But it would take too long to go into those. But maybe at some stage, I could send you a study on that has a phenomenological lens and a study that is based on narrative inquiry. And then you can see the differences between those. But there is a relationship between the two, I would say. There are some similarities. Okay. Colleen, are there any other questions in the chat? Hello, am I out?
No, we can hear you, Doc.
Oh, okay. I think Colleen is frozen. Because I see she's gone out. Okay. Are there any other questions? If I'm considering narrative and will be compiling, is it necessary to Viloshni.
Yes. I do have a question. Question something.
Okay, 1 second. I'm just looking at this. If I'm considering narrative and will be compiling this, is it necessary to send the participant? Okay, so this is the other complication in qualitative research. Once you've interviewed a person and you've transcribed it, or they've told you their story and you've transcribed it, the general practice is to send it back, because the reason is that the participant may decide, I want you to remove this statement I made. I want you to change that. And we allow for that, because remember, in qualitative research, we are not hunting down the truth. We are looking for a perspective, an opinion, an attitude. It's not the truth. It's one person's construction of the truth. And therefore, we allow the participants, we give them lots of rights in this research. So certainly we will do that. Mutugeta, I think, was it you who wanted to ask a question?
Yeah. Just I want to understand the difference between the ethnographic study with grounded theory, but it was not mentioned here actually. And if you have any explanation on that.
Okay, so it is a different approach to ethnographic study. They are quite different studies. So in an ethnographic study, you go and you embed, you live in the place. Generally, it was a study of cultures, and people sort of from America went to an island and lived with the people for 2 or 3 years in order to understand them. Of course, the early studies were very problematic. They came back with the idea that the people were uncivilized, they were half naked, and so on. Modern studies are far more, what you call it, how could I say, ethical, in terms of ensuring that we understand it from the people's point of view. So you stay there, you are a participant, you're a researcher, you observe. There are stages in which the first stage is called the observation stage. The second stage is where you go and integrate and you start looking at things and using your research instruments. And the third one is you get a focus and you hone in on the focus and you get much more data on the focus. And it's a long time. So an ethnographic study could be anything from 6 months to 5 years. So it's, you determine. There are shorter ethnographic studies. There definitely are. Grounded theory, on the other hand, is an approach which wants to develop a theory. In the ethnographic study is to understand in grounded research, it is to ensure that you can create a theory at the end of it. So grounded research is quite different. I would need an entire session just to do grounded theory on its own. But I hope that just hints that there are major differences between these approaches. And I want to make this offer that if any of you feel that you want to know much more, either about an instrument, an approach, or a perspective, a worldview, or whatever, you can just write to me and say, 5 of us would like to, we can just have a Zoom session for about an hour or so and talk about possibilities and so on that matters to you. Because qualitative research, when you're just starting out, is really helpful if you can get somebody with experience to guide you through the initial stages, and then you're on your own, then it's fine. I'm offering my services as sort of a mentor or a guide to assist you, and I could bring other experts in who are far more knowledgeable about particular approaches. So there's an example who's excellent at self-study research and so on.
Sorry, Nana, I was knocked out for a few minutes.
Yes, we realize that.
Yeah, have you just been attending to the questions in
Yes,
the...
I have been attending to the questions.
Okay. Are there any further questions?
Can I use narrative inquiry and phenomenological research together? I think you can, Viloshni. I think that's you asking the question. But I would suggest, why punish yourself by making things so complex? Both of these are complex enough in themselves. And you would just be really, look, when you are starting out in qualitative research, don't start off in the complex way. Start, I would say, in a more simple, clear way. All the simple ones are not easy, let me put it that way. But you could make it more manageable if you stick to one approach before you start the combinations. And I can tell you, for starters, sort of narrative inquiry is and case studies, I would say, are the starter modes to move in. But you could do any one. It doesn't mean that you can't. Discourse analysis, I would say, really is a little bit later.
I think I wanted to make a comment earlier about the subjectivity and objectivity. And I think a lot of people are uncomfortable about that. I mean, I'm going to ask Antoinette Chateau, who was in the audience. Antoinette, are you able to speak, or are you traveling? Sometimes I know you can only listen in.
I'm here, she's going to have to speak.
Yeah, she often can't because she's
driving.
No,
I'm joking.
Yeah. But so I'll speak on her behalf if she can't come through. I mean, something that Antoinette is trying to find out is how caregivers feel about treating these children with this very often a terminal illness. And it just, when you look at this illness, you just wish that you could just do a skin transplant and this child will live, but it's not like that. She is not going to be subjective in her approach. So when we're talking about subjectivity and those kinds of things, it's subjectivity and objectivity isn't as big a thing that if you are now trying to do some research on gender-based violence, and you are a woman who was subjected to GBV in your childhood, and you are going to go into an interview, or you're going to analyze things with that kind of background, you are going to be subjective. Okay. Nana, am I explaining this correctly?
So maybe let me just complicate the discussion a little bit. So in its simplest form, subjectivity and objectivity is refers to how involved the researcher is with the study. It's not about the participants. So you, as the designer of the study, try to ensure that you are as objective as possible. So objective as possible in the positivist approach is you have real, stringent criteria for who participates in the study, stringent criteria for how any intervention takes place, how the observation will be done, how the measuring instrument is checked and rechecked and refined to make sure that it measures what it states that it measures. And all those reliability kinds of things. That is what is referred to as objectivity. And in qualitative research, we don't take care of all of those to that extent. So we know that we can refine the instrument, but because every human is an individual with moods and feelings and experiences and all that constructs them differently, they're going to be responding differently to questions which are posed in an oral form or in a written form, because they bring their interpretation. So we can't control that objectivity to the way research in the positivist sense. I know when I used to conduct IQ tests, there was a written script and we had to practice our tone. So every group that came to us, we used the same language, the same tone, and all of that. We tried to control everything. I'm sure I coughed in between, but you know, we have that idea that we are objective as possible. So that's one idea. But I think the other thing, when you were talking about the caregivers, it's not so much subjectivity there as much as emotionality. They are emotional about their involvement in taking care of children. For one, it's almost impossible to carry those kids without causing them pain. And knowing that they are going to die. So they are very emotional. They want to stop this child's suffering. And it is how Antoinette is going to capture and describe that emotional component that will bring some level of objectivity to the study. I don't know if you get what I'm saying, because in qualitative research, from a philosophical point of view, the notion of subjectivity has a different interpretation. And subjectivity is in opposition to identity. So identity is how one constructs oneself, who I am. This is who I think I am. These are my views, my values, and my desires and agendas and whatever it is. I am a South African, I'm not from India, and those kinds of talk that happens. Subjectivity, on the other hand, is the construction of the self, which is ignorant of the forces that shaped it. So I think I am a libertarian, and that I want that, you know, I will always promote a person's right to choose. But I don't know if that's my idea, or whether that idea was planted in my head. And then that idea could be reshaped by somebody else, another power, even against my will. So that is another form of subjectivity. And we have to be very careful around how we understand it in a study, because sometimes when a participant talks about empathy, about care, then that is interpreted as subjectivity. It's not. It's the experience and their feelings. And then we have to theorize those. That's what makes it so complicated and complex. I hope that clarified it by complexifying it.
Yeah. I think also the way evidence-based medicine is taught, it's they've interpreted, they've changed the David Sackett interpretation of certainty to be quality. And so when you are doing a study on, say, looking at the caregivers of a terminal illness in children, and you're saying there's going to be some subjectivity, it doesn't mean that there is a lack of certainty in that. And it certainly doesn't mean there's a lack of quality. And I think the biggest mistake that's ever been made in evidence-based medicine is creating a pyramid that has been interpreted as a quality pyramid, that the higher up in the pyramid, the better the quality. It's not. It's about certainty.
So there's your project, Colleen, is to write the challenge to that. So I'm really proud at the moment that I have challenged Maslow's hierarchy of needs And I've now been asked by the British Psychological Association to write up that paper. They were so impressed at the presentation in which I turned the whole thing on its head and showed that it is irrelevant and makes no sense in certain contexts. So I think we must constantly do that. The other thing I want to say is maybe if you change the language, you change the understanding. So maybe we need to find new words for subjectivity, objectivity, new words for certainty and quality. So, and set up our own frames of reference. That's what research allows you to do, the production of new knowledge. Because I think, let me just make this one point, Colleen. You see, qualitative research is more, provides more opportunities for you to create new knowledge and to challenge existing one. Because in the other one, it's the application of the knowledge. And here, what will emerge is something new.
I've come to see that qualitative research poses new hypotheses, and quantitative research can either prove or disprove the hypotheses. So we've gone past our hour, and we could talk for another hour or so on this, and I certainly would like to see a lot more. When I see sitting at break, I would like to see a lot more people expanding their research repertoires to look at how patients feel, how caregivers feel, because how they view things will impact on the quantitative work that you do as well. So Nena, again, thank you so much for this talk. For everybody, this should be on the YouTube channel, UKZN YouTube channel by Monday, the latest, if you've missed parts of it, or you would like to watch it again or send it on to any colleagues. So we'll see you again next week, same time, same place. Thanks for attending, everybody. Bye-bye then.
Thank you.
Bye.
Bye.